So good afternoon. It is exactly 2:15, and I'm delighted to have you all here. My name is Ned Reimer, and I lead the health sector and life sciences here at Questrom, and also lead the health sector management MBA program. I am delighted to be the moderator of this panel on payer and provider. We've had a full load this morning of all different kinds of content. And the opportunity for us this afternoon is to drill down a little bit more into what does the provider space look like, what does the payer space look like, and in particular, how do they interconnect? I'm going to frame a couple just very simple, broad ideas, and then I'll introduce the panel. And then they will share a little bit about the lens they see the field in from their place of work. And then I will start the discussion with some questions. We'll go from there, and I hope to turn to some of your questions that you'll be developing over the next 40 minutes to turn it to you to ask the panel some questions. I think we're at some very interesting times that we sort of heard about this morning. And I thought one that sort of came up from Peter Slavin when he kicked off the morning was just some of the trend lines that are really driving healthcare in this country. So when you think, or when I think of, I'm the tail end of the baby boom. I was born in 1961, which means that since 2011, there have been 10,000 people a day turning 65. About 20% of the U.S. population by the year 2030 is going to be over 65. So why is this relevant in healthcare? So according to the data, approximately 50% of all people over 65 have a chronic condition. Actually, it's 80% have a chronic condition, 50% have more than one chronic condition. So that is very relevant for healthcare. When you think about how it gets paid for, even more relevant. So when we think about how we provide care, to who we provide care, the cost of care becomes really relevant. Secondly, this whole notion of money. How, and the insurance industry has been changing a lot, so that's part of the panel representation today. How we pay for care, where we get our care, can we afford our care? These are all driving issues. So when we think of the big thing, the mantra that you even heard this morning was value-based care. Cost going down, quality going up. Easy to do, right? We should figure it out by tomorrow morning. We'll find out. The context, though, I think around how people get reimbursed and how it relates to providers is very relevant for this panel and for all of us, which is, the little things. Even things such as, I'm just going to give you one example, the patient experience. Patient experience is being measured. I was talking about Prescania this morning. There are lots of different ways to measure it, but when it gets to Medicare and different types of insurance reimbursements, the patient experience actually determines how much you get paid now. That was not happening 5 years ago with HCAP scores, etc. So these survey instruments, and sometimes the return rate is actually quite small, decide how much money you get back for a certain type of service. So the fee-for-service, we're still in that world. We're moving to a value-based reimbursement system, but we're not quite there yet. So we're in this in-between. It's a challenging time for healthcare, and we're going to learn from our esteemed panel sort of how this all fits in, the interconnection between payers and providers in this very dynamic stage of healthcare. So with that, let me share a little bit about, introduce our panels. You guys have their short bios, so I'm not going to share that information with you. I have to my right David Kirk, Jim Donohue, Andy Sussman, Jane Maffie-Lee, and John Kingsdale. I've gotten to know them a little bit. We've shared a little bit of their work. You see their bios. But what I asked them to do is sort of briefly, in 1 or 2 minutes, share a little bit about their professional lens on the provider field and or the payer field so that you understand the position that they're coming from today, so that you understand the perspective that they bring to this topic of healthcare from the provider and the payer perspective, so that you understand their background. And then I will start asking a few questions of them, and then we'll get us into sort of a full group discussion as we proceed. All right, so David, why don't we start with you?
Sure, so I'm David Kirk. I'm with Cognizant Technology Solutions, our services, I think, but I'm part of their business consulting practice. And what I focus on with Cognizant is bringing health plans into the digital age. We have a very strong digital transformation practice, and I've been working with health plans on how do you create that digital member, if you will, and provide the services, tools, and technologies for them. And what I find very interesting about this particular topic in this panel is, as we heard from the first speaker this morning, MGH has 200 health plans that they have contracts with. So when you have that complex of a provider and payer mix, how do you connect it all together so you can create a seamless member, seamless provider, seamless consumer experience? So that's what I've been focused on.
Jim. So I'm Jim Donohue with ECG Management Consultants. We are a consulting firm focused on the provider side of the industry. My area of focus is on managed care strategy, and what that's meant primarily over the last 5 years or so has been helping organizations to think through how they change the way that they're paid and they change the way that they're organized in order to deliver on some of the promises that we've been discussing, of value-based care. So some of that and a lot of the work that I'm doing focuses on how do we change the structure, create clinically integrated networks of physicians and hospitals, not just employed under one system or one tax ID, but those that are across a broader geography. How do you bring in the community physicians who aren't employed by a health system but provide care to patients who receive care within that system under one network so they can work together collaboratively? And some of that involves financial relationships, legal relationships, IT infrastructures, et cetera. Increasingly over the last several years, you've started to see the incorporation of the payers within that construct, within that integration, either through the formation of joint ventures or simply through the contracts that are established between payers and these integrated provider organizations that go beyond just pay for performance, meaning paying in transition to models where you're truly providing incentives to invest in the resources to be able to manage the total cost of care for a population.
Great, thanks, Jim.
I'm Andy Sussman. I'm an Executive Vice President at CVS Health and the President of MinuteClinic. We operate at CVS about 8,000 drugstores around the country. We also have one of the largest pharmacy benefit management companies, Caremark. We manage the pharmacy benefit for about 65 million Americans. And we operate over 1,000 MinuteClinics now in 33 states. So the comments earlier about an aging population beset with chronic disease are very relevant to the environment, as is the shortage of primary care physicians, which is fairly profound around the country. In an environment where we're expanding access to coverage, we don't have enough access to care, which will continue to be a challenge. We also are in an era of consumerism, which a quarter of people today are on high deductible plans, where the cost of their care is much more central in their decision making. So value between payers and providers and frankly patients now is much more paramount in decision making. MinuteClinic operates, as I said, over 1,000 clinics, the fastest growing walk-in clinic chain in the country, the largest. And we have nurse practitioners seeing patients 7 days a week on a walk-in basis for a variety of conditions. We continue to expand the scope of services and are affiliated with about 65 major health systems around the country with integration of records and working with their physicians in a variety of different ways. We have a lot of focus on digital and telehealth and a number of progressive areas where we can add value. So our interest is continuing to help people on their path to better health. And I think a good example of that is eliminating tobacco from our stores, which we did earlier this year as part of renaming of our company. So there's a lot going on at CVS. We're the largest healthcare company in the country by retail, and hope to continue that discussion today.
James.
So I'm sitting here listening to my wonderfully esteemed colleagues here on this panel, and I'm thinking to myself, I'm not that important, but I am important. And so my population is more like, instead of millions or thousands and thousands, it's more like 4,000 patients. I work at the Ambulatory Practice of the Future at Mass General Hospital. It's been open for about 5 years. And it was established, or at least the brainchild of a doc who was seeing 30 patients a day, getting totally burned out by seeing so many people, and thought, I'm failing. And, you know, I don't know if you know much about doctors, but doctors had to work really, really hard to get into medical school, and then they had to work really, really hard to get into good residencies, and then they had to work really, really hard to get into good fellowships and on and on. And so a lot of healthcare people are really interested in succeeding, but when you have 30 patients in front of you and you're trying to work through this and trying to do the best that you can for them, it just doesn't always work out. And so people like that don't like to fail. I certainly don't like to fail either. I am a nurse practitioner and have been a nurse practitioner for about 15 years. I love my job. I love what I do. I take care of, I don't care if you want to call them patients, clients, or people. They're all the same. Well, no, they're not all the same. Everybody is different. And I am really honored to work in a practice where we think about value, we think about patient experience, and we think about patient engagement.
Thank you. Jen?
That sounds important.
I feel important.
So I guess my perspective is, having spent 25 plus years on the financing side, basically private insurance, and I got involved in marketing when I started and ran the Massachusetts Health Connector here. Now I always have to add that when it worked. And have been consulting with states and CMS and private clients trying to figure out how to get into this new world of business to consumer relationships and marketing in the insurance field. And I'm actually have left all those organizations, so I don't have, I can't boast about anything I'm particularly affiliated with. I'm also teaching at BU and doing some research, mostly on consumer choice. So how do consumers choose health plans, how to structure choice, gets into kind of the behavioral economics that has become fashionable in the last 5 to 10 years. And that's what I'm particularly interested in. But I do carry the bias from my old life of insurer and provider.
Thank you, John. Well, let me actually start with you, if I could, John, because you were picking up on a theme that we had discussed during a phone conversation and prep for today, and that is around consumer choice of payer. And you mentioned on the phone that there's some real trade-offs around this, and maybe even some impact on transparency. Maybe you could allude to that as the first question.
Well, there's a sort of in the particular area that I'm most interested in, which is how do individual consumers or households pick a health plan, and then how does that translate? Because if you follow the money, the health plans have the money, they give it to the providers on certain terms, et cetera. So it kind of flows down from there. So it's an important choice, and this has been almost entirely a B2B business. I like to say that actuaries are born in 6 tuplets, that they only like groups. There's lots of reason to pool risks and think about groups. And what's the growing part of health insurance now is the individual direct-to-consumer sale. And so how do those people make choices? And there's a lot of ideology in this. So there is a kind of standard Republican, government shouldn't interfere, everybody should have free choice, and a standard liberal, no, everybody needs some help and guidance and so forth, so I'm making these choices. And I'm interested actually in doing research on what works, because I do have a bias, which is that unstructured choice, I can't remember more than 3 things at a time. And so I kind of take myself as the typical consumer, particularly as the rest of the baby boom catches up with me. And so I have some biases about the importance of structuring choice, but actually doing some research on that now. So I think it's a rich field to try to figure out how do we structure choice of the sort of the top of the pyramid financing source so that it then flows down. One of the things that's quite clear, for example, is how extremely price sensitive individual households are when they buy insurance, far more so than employers. And my friends and partners discovered this intuitively about 15 to 20 years ago when they told us that they would not let us, they would use all their market leverage, which is substantial, to keep us at the Tufts Health Plan, which is where I used to work, from giving individual consumers a choice of health plans at different price points, because almost all of them would pick narrow networks for the lower price. And of course, that was exactly the wrong time to make that choice. They should make that choice when they're in the throes of a crisis and they need a provider. So you can see my bias.
Thank you, John. Let me turn to you, Jane, if I may. When I spoke to you about MGH's ambulatory practice of the future, you spoke a few times about this notion of volume to value, and also just the culture that you try to build around patient engagement. Can you just speak a little bit more to that?
Sure. So our practice thinks a lot about kind of a new paradigm of care, and one of those things is going from a volume to a value base. Now the problem with that is money, right? I mean, if you don't see enough volume, you're not going to get enough pay, and you're not going to be able to support the people who work there and pay the rent and that whole thing. So the founding people who started our practice basically made a deal with Mass General and said, listen, we're going to open up a primary care practice, and we're going to take care of the people who work here and their spouses. And we're going to compare ourselves with, as a primary care practice with other primary care practices with like members to those primary care practices. And we bet that we'll do better. And so our volume in our practice is measured at about 70% of what other practices are. We spend, and people hate this, physicians hate this, Andy, don't close your ears. We spend about an hour with our patients. Physicians do and nurse practitioners do, for especially that first visit. And so our physical exams are almost an hour. So some of that hour is taken up by our team members who are prepping the patient, and they do a lot of the interviewing, the stuff that we don't have to do, and feeding the computer so that we can spend more time with just talking to our patients eye to eye. And so that's part of the volume to value. The other thing that we do that I think is very different when I ask my colleagues who work in other practices is we really think about our culture. And what I mean by that is that the front desk person who gets paid not a lot of money is just as important as the physician who's seeing the patient. Because every single person in our practice is important in some way to help us think about the population of people that we take care of. So providers' offices, you see who comes to you, but there's got to be 30, 40, maybe 50, well, maybe 40% of the people who don't want to come to you all the time, and will only come to you when they're sick, or maybe they won't come to us, maybe they'll go to you, and that's okay. That's okay. But we still see ourselves as really responsible for that care. And so a provider who's busy all day with patients and then has to sit there and write charts, half the night away, is not going to be thinking about the patients who have not come in to see them. And that's where the other team members help. So we have systems where our medical assistants reach out to patients, our front desk people reach out to patients. We have 2 health coaches that help us do that. We have some innovation that helps us do that around diabetes and hypertension. If I have time, I'll tell you about that. But that all comes from deciding that we're going to do that our culture is going to be different. It's not going to be kind of physician-centric. It's not going to be that the physician says that this is going to happen, so it's going to happen. We have team meetings, or staff meetings, actually. We're a small staff. And the leaders of the organization do not run those. Like I'm one of the leaders. I get to run that meeting about once every 6 months, because a front desk person will run that meeting 1 week, and the next week it will be a medical assistant, and then the next week it'll be one of our health coaches or our nurse. And so in that way, all of the positions are kind of valued and talked about. And we also make an effort to, and this is an effort. We talk about this and we think about this. We gather together for parties sometimes. There are some practices who the docs go off every day, or the nurse practitioners go off every day. They don't even know each other, and in kind of a personal way, and that helps bring us together. I don't know how. I hope we can keep on protecting that, but that's kind of what I mean by culture. Yeah.
Quick question. Are you guys self-sustainable financially, or do you require a certain stipend from Mass General to cover for
Yes.
these providers are spending an hour?
So yes, we do have a stipend from Mass General to see patients. You know, part of it is that our rent is so much, and we're really working hard about trying to push people toward a per member per month payment model, because we feel like we can succeed in that way.
And do you think as this expands moving forward, and then you cut costs from patients not going into the hospital or other costs, do you guys envision this in the future being being financially sustainable? Or is it something you can expand to the entire hospital?
So when docs from other practices or nurse practitioners from other practices come and talk to me and they go, oh, well, you know, you're the ambulatory back to the future, you're special. And I go, please, you have to hope that we're successful, because this is a really wonderful way to see patients. Not only do I go home feeling very good about my patient care that I did, not only do I have time to engage a person in their practice, and they can also, all patients, by the way, when I sign my note at the end of the day, a patient can go in their medical record and see everything I said. So we're very open to you know, what we've said with our patients. But we want us to be successful. So what we see is that at the very beginning, our costs when we see brand new patients are much higher than other practices. And then as time goes out, we keep people from the emergency room more than other practices do. We have better access more than other practices do. And we think, but this takes years to figure out, we have less of our patients' heads on those beds in the hospital. So yeah, I think there's a gap there where we begin to make money and save money for the hospital.
Thanks, Jane. We'll come back to a couple other points, particularly around the culture question, I think, in a little bit. But Andy, I'd like to turn to you for a moment. In your introductory comments, you mentioned a little bit about MinuteClinic and value-based care. I'm curious if you could go a little bit deeper on just how, you know, this whole notion of consumerism in healthcare, how you're really changing the marketplace. I went to my local CVS just last weekend and picked up a little MinuteClinic brochure, and one of the words on its front is convenience. So I think you're really framing MinuteClinic in a whole new way to the marketplace. So can you share a little bit more about that?
Yeah, you know, thank you for coming to CVS. I think if you think about where we are as a healthcare system, the focus on access, quality, and cost is really paramount. And finding different solutions to that. And actually, I think you're going to hear a bunch of different solutions today on the panel. When we think about it, you think about access. In our 1,000 clinics, about half the patients we see don't have a physician. And I mentioned earlier about the shortage of primary care physicians in an era with an aging population and a lot of chronic disease. We have 25 million people have diabetes in the United States, 70 million more have prediabetes. They're going to develop that disease in all likelihood over the next decade. Who's going to take care of them? So a lot of patients we see don't have a physician. Half the patients we see are evenings and weekends. So take that problem of shortage of providers and then be sick on a Saturday or Sunday or Thanksgiving, and the alternatives are not good. You then put in an environment where people are a little more sensitive to the cost of the care. You start to get a change in various kinds of healthcare provider behavior. So from an access point of view, MinuteClinic offers walk-in care 7 days a week, which is a very big asset in terms of the way people think about us. From a quality point of view, we're accredited by the Joint Commission. So those of you in healthcare know that's a pretty high bar to reach. They actually go up to 115 CVSs around the country, if you can imagine this, and say, hello, we're from the Joint Commission, and put us through the same white glove testing and surveying, watch us practice, and we've been reaccredited 3 times. So our model's been studied, a number of different quality studies, and we've done extraordinarily well. We follow evidence-based guidelines for all the care that we deliver so that there's a standardization that is uncommon in medicine but leads to really excellent and consistent outcomes. So the same care you get in California is the same care you get in Connecticut for a given set of symptoms. All of our clinics are on Epic, the same Epic electronic record, which is then integrated with multiple health systems around the country. And on a cost basis, and this gets to what John said a little bit, all of our prices are transparently posted. So you know how much it is when you go there, or what you're going to pay. We keep our costs low by using a kiosk to check people in, like in an airport you would see. and being consistent in our clinical practice. When it's been studied by the RAND organization, the average costs are 40 to 80% lower than other sites of care. So if you think about the environment we're in, you have walk-in care delivered by nurse practitioners practicing at the top of their license, using evidence-based guidelines, and doing so in a cost-effective way. It's right at the sweet spot of what a lot of Americans are looking for in their health care. Not replacing the primary care medical home, but complementing it and supporting it and filling in the gaps, because there are a lot of gaps in the current system, gaps that people are hoping to solve in order to get value and really the consumer is looking to resolve. So we think we can play that important glue and be the backstop and frankly direct a lot of people who are without providers into the traditional healthcare system. And so that's a part of the role in terms of access and quality and cost.
Can you speak a little bit more, though, Andy, on the role, you mentioned Epic, but the role of technology within the MinuteClinics in connection to the 60 somewhat affiliated health systems that you're connected
Yeah,
with?
so technology never solves the incredibly important and intimate and compassionate role that a healthcare provider plays with their patient, right? Technology itself is never going to be between that. But technology is a tool that can help us to communicate with each other. So, for example, with our EMR, it's integrated with a number of the health systems in the state of Massachusetts and really around the country. And we can get clinical information about patients we're seeing, and our notes can go to those providers almost instantaneously from the patients that we care for. So that's one way. I mentioned about using a kiosk to check people in. It sounds kind of simple if you're in an airport, but in healthcare, we haven't really done that. We still have the expense of having people do work that a machine can often do to replace. And I think that there are a host of digital technologies that are now coming along. We will be launching very shortly, actually next month, an ability to sign in for one of our clinics from home so that you can use your digital device. We have telehealth pilots in California and with a number of the big telehealth companies. I saw you had Ito here this morning, using telehealth to augment the model and provide access. That's where things are going. I mean, it's going to be tremendous, and John can speak, there's a tremendous downward price pressure on healthcare. I mean, even though we've already seen it, when we're talking to clients or some of the largest employers in the country, that is not going to abate. They are all over that issue, and so where there are less expensive, high-quality solutions, those will continue to be important. And I think digital and telemedicine and all of those solutions have an important role that can help consumers and patients get good quality care at a reasonable cost.
Thank you, Andy. So, Jim, one theme, and John sort of kicked it off, was, follow the money, right? So the money is driving a lot of things in healthcare today. You spoke to me earlier a little bit about the impact of these mergers within healthcare. And I'm wondering if you could speak a little bit more about the ways to engage patients around their own health and patient engagement, and what you're advising some of your clients in sort of the patient engagement and transparency area.
I'm going to take some liberty and go a little bit in a different direction, if that's it.
Yeah, that's
what place I'm. So, as I think about the impact in terms of following the money, I think we've got one overly simplistic version of the way of looking at this issue. Is you've got providers who are delivering the care, and a lot of the focus has been on thinking about integrating the provider. So, how do we do all the things that we've been talking about here, and I'm sure you guys are studying in your classrooms, to coordinate our care across various settings. We've also got patients and we've got payers. I think one of the things that we're starting to see some traction on incrementally is starting to bring together the incentives and the coordination across the payers and the providers. I think we've got a lot of work to do on the patient side. And I can comment on that too. But one of the things, we're starting to see a blurring of the lines as payment systems evolve of the functions of provider organizations and taking responsibility for caring for the entirety of a population. So not just when the patient presents, but also when the patient hasn't shown up. When we look at the historical functionality and strengths of a payer has the entire picture from a claims perspective of a patient. What's their age, what's their demographics, other basic information, what's their diagnostic history, what's their costs, what's been going on with them in terms of the care that they have received. Providers have historically only had the information related to what they billed. And so they've got a narrow picture of it. And so the opportunity to start to bring that together presents some potential. So I think that's when we're talking about the theme of this being disruptive innovation. I think that presents the opportunity to do that. I think it gets disruptive when we actually are able to execute on it. And I thought about there's one really fascinating model that's developing. It's confidential, but it's in a southeastern state. The United States, there's a statewide clinically integrated network of about somewhere between 5 and 7 health systems that are coming together to form one network. Associated with that is one of the 3 largest health plans in the country is in a joint venture with that emerging clinically integrated network, with the plan of moving all of their members, 100% of their commercially insured members, into this joint venture, where they're going to share responsibility for developing products, of health plan products, of marketing them, of sharing information for all of these patients, and sharing in both the investment, but also sharing in surpluses or deficits associated with it. And so something like that, from my perspective, starts to align the incentives, the money, across the various participants in innovative ways. We'll see if it's successful, but I think we're going to start to see more areas of innovation. If I can do one last thing, yeah. One thing that I think in terms of innovation that's been a disappointment to me is on the patient side, when I look at benefit designs, it's still an incredibly crude instrument. I'd see us developing all of these new ways of paying providers to care for the patients. I haven't seen much in the way of new innovative ways that we design the benefit structure for patients. It's where we see a transition to PPO plans, which can typically share more, put more of the cost burden on patients. We also, and separate have a looser link between the primary care physician and a patient. We also see the rise in high deductible health plans, which I haven't seen models where they're really trying to be thoughtful about exactly what types of care you're trying to provide disincentives for patients to receive, but more importantly, what types of care you're trying to provide incentives for them to receive. And I think that's an area I'd love to see us make some more innovation.
Well, I think one of the challenges there is with the moving to on the TPO side, you have patients that want to have relationships with doctors, right? And then you're on the other side, where you've got the global risk. You want to get patients to have the relationship with the system and the network, right? And so it's how do you bridge that gap, right? And I think that's re-educating the patient, right? So they.
So that was actually going to be my question for you, David, which was when, historically we have had patients have relationships with doctors, and you had shared with me on the phone. So this whole idea, which Jim was really alluding to, of integration of payer and provider together. And how do we sort of move patients, people, consumers, clients, from the patient doctor to the patient system and feel okay with it? Do you have some ideas around that, how to do it, how to get there?
Well, I wish, because then healthcare would be solved. I think, and I don't mean to be flip or glib, but one of the things I've learned is in the number of years I've been in healthcare is local. And you have the relationship with the provider at the local level. And I think it was John that alluded to the actuaries like the groups. Well, now with guaranteed issue and no pre-existing conditions, we don't necessarily have to go through that whole underwriting cycle that we had before. So the opportunities to have these provider-owned plans it's really exciting. And so you'll see how Aetna and United are focusing more on becoming, instead of insurance companies, services and technology companies. In the company I work for, Cognizant, where we support and the underpinnings of that, and we're I came from Optum, and we had this concept of a health plan in a box, right, where you can do all of the back office work of a health plan. So you could have this provider group that could take risk, and we would do the administration of that. And so to seeing Cleveland Clinic and Mass General and these other, Sutter Health, Sharp, all these hospital systems that are taking risk and building plans and selling that, it's really exciting to see how it's becoming local. And there are these local systems, but with the technology that can be done on a national, that traditionally only the really large guys could do, right? Because United Health Group has $1 billion IT budget. Not everybody has $1 billion to spend on tech, but you have access to that now. So it's really exciting to see that. So I think it's going to be painful too, because we talk about health systems, right? And one of the things I heard today that I thought was really great is we don't really have health systems. We have really complicated health arrangements. And unless you own that whole end-to-end spectrum, like a Kaiser, where you can really guide that, it becomes very challenging because you have the.
But to your point, ownership. I think ownership can be confused with being a system in your concept. So there's plenty that own. They're all under one financial umbrella. It doesn't mean they work together.
Right, and when they're all under one financial, it takes forever to get the division of financial responsibility lined out. I'm not going to take that risk. You have to take that risk, and back and forth.
So let me broaden the discussion a little bit here, and this isn't pointed to any one of you. I'm just curious on anyone's opinion on this, but I alluded to the demographic trend lines of the baby boom. Baby boom has some history in this country. Baby boom likes to, and because on the tail end of it I can claim such things, to have actually created some change in this country. Generally things for the good that we like to take credit for, things like civil rights, women's rights, and a lot of other things, environmental concerns. I am curious what the baby boom is going to demand about how we live with chronic illness, given the trend lines, and how we die, and how that's going to impact providers and payers in the next 20 years. Does anyone have any ideas about that? In other words, I see it as the baby boom legacy project. Is how we live with chronic illness and how we die in this country, given what we've just been talking about. John, you want to kick it off?
Sure, I have a thought. I think we have tried in this country to draw a fairly clear line between social services and long-term care on the one hand, a lot of housing, activities of daily living involved, and acute medical care. It's really a gray area, it's really a continuum, and for us old people, more so. And so as the pig and the python moves towards our 70s and 80s, beyond 85, a third of us are supposed to have dementia, and a lot of us are living beyond 85. Those kinds of lines really become dysfunctional. I don't see with our current environment any good systematic responses to that. I do think we will reconstitute the three-generation family, where the grandparents move to all the kids, take care of their grandchildren, and then also get care of themselves, sort of banking away some emotional, building emotional bank accounts so the kids can take care of their parents after their grandchildren.
Anyone else? Any other thoughts here on sort of what the baby boom is going to be demanding around our care with chronic illness?
I can just talk a little bit about what I see with the patients who I take care of, and I'm a baby boomer as well. And there's two ways to look at it. I guess one of the things that my responsibility is to do is to engage people in their care. And when I go to bed at night and I'm thinking about all these people, and the bottom line is that we do a lot of stuff that's really bad to ourselves. We don't exercise enough, and we eat too much, and we drive fast cars or whatever. We do a lot of things that kind of hurt ourselves. And sometimes I don't see us take responsibility for that. So I see that providers, I think myself, I'm not in the business anymore. It's really wonderful. I don't tell a person that they have to stop smoking, and I don't tell a person that they have to lose weight. I try to engage the patient into what they really want to do with the rest of their lives, or how they see their life on a projection. And then I say to them, so now tell me how you think you're going to get there. because everybody knows that smoking is bad for you, and everybody knows that eating too much and being too heavy is bad, and so I don't have to tell them that. And it's really quite freeing, I have to tell you. And so I worry about the baby boomers demanding, give me a pill and make it better. And I don't see how that's going to happen. I don't think there's going to be a pill for everything. And I hope that the relationship between providers and their patients will help patients, the baby boomers who are getting sick, understand what it's like to take, that they understand their own responsibility in it. I don't know if that quite answered your question, but at least from my perspective, that's what I see.
Anybody else want to come out? Right.
I would just say, I mean, I think that the one of the profound challenges is that what we're able to do for people continues to grow with each passing year. Only now the number of people we could do it for is growing also. And whether we can afford to do that, we're going to have to be very cautious about how we use various treatments, therapies, and resources, and be evidence-driven about what really works. I think that's going to be a challenge. I know in our area, in the pharmacy, their development of new medications that can do remarkable things is just exploding. The fastest growing area of healthcare inflation is in pharmacy, particularly specialty pharmacy. So we have, on the one hand, a remarkable group of scientists and capabilities now that we never had before. On the other hand, if we don't use it responsibly, we'll use every last cent we have for education and defense and every other social service, taking care of people, and we have to be thoughtful about how we do that. We just developed a cholesterol medication that costs 1,000 times as much as the oral treatment does. So we do need to consider what's the right and appropriate use of those therapies. And certainly a baby boomer generation will have a high expectation of when we use it. And I think that's a challenge we all face. And by the way, it's not just a political challenge, it's a challenge for everyone who runs a hospital, everyone that runs a healthcare company, everyone that runs an insurance company, about how to derive the best value from the remarkable scientific accomplishments, and so that we use it in a thoughtful way.
Let me pick up on just one of the themes of today's conference, and also particularly this panel around providers and payers. Someone asked me just after lunch, and I wanted to make sure to frame it this way, is almost an assumption that transparency and patient engagement actually improves healthcare. I mean, like, is it an automatic? I'm just wondering if anyone has a perspective on that there are certain situations where transparency and or patient engagement does not necessarily lead to better healthcare.
I think that patient engagement doesn't always lead to better healthcare. We were talking at lunch about some of this stuff. It's like there's this push to have shared decision making, between the provider and a patient. And sometimes my example about this is I'll sit there and go through a shared decision making module with a woman who's 42 years old who's thinking about having her first mammogram, and she'll look at me and her risk will be low, and she'll say to me, "So what would you do?" And I go, "Well, that's not really shared decision making." And so I could tell her what I would do, and yet I know that I have a colleague who's doing the same thing with the patient, who would tell that patient the exact opposite of what I would have told that patient. And so I don't know if patient, we can say that we invite patient engagement, but that doesn't mean patients will be engaged. And that doesn't mean patients will do the best thing for themselves. And that's just human beings.
And I think to compound that is the health literacy aspect of it as well, because I know in a lot of the work that I have to do, when you're designing these systems for people to interact with, you have to make sure that it's something that's understandable. And I think when there's too much choice and when there's too much information out there, you can get overwhelmed. And one of the things that I think is often lost when we talk about consumerism, when you're talking about shopping for healthcare and health services, it's not like shopping for a washing machine. A lot of times people are sick when they're having to make these decisions and have this information put at them. And so to give them, this idea that they can make those decisions for themselves, I think we have to be a little bit more thoughtful or compassionate about how we can guide them through, but do not necessarily like a black box around the doctor. You have to listen to what I say. But
And David, just to go a little further on that, you had mentioned to me this whole notion of, payers and providers are often based on these old legacy systems and relationships. And how do you sort of leverage or tilt change towards something new? Do you have some thoughts about that?
I think it's really exciting to see like what Oscar's doing. And the difficulty with that, though, is if you take a company that has 38 million members that has a 38-year-old legacy system, to be able to make that do what Oscar does is impossible. So you have to start, take a new code kind of approach and try to migrate people into new ways of doing things. But the problem that I see is it's very difficult. Unfortunately, you have the institutional inertia where they don't want to move off those systems because the production systems is business as usual, and that's what's generating the revenue. So until it's a truly proven model that they're going to be able to completely move over to, I see it as, we create these sort of bridges and decoder rings to kind of translate between the systems, but it becomes very difficult, especially, when you have 38-year-old claim systems that are have some data quality challenges, and then to have those integrate seamlessly with a provider portal to give them that information. I mean, on just looking up what my chemotherapy benefits are, or knowing what my, the cost of a certain procedure is. I know the transparency tools are getting better, but it's unless you fall into that specific group of services that they have the cost information on, you're still in the dark. And
One other way that I sort of thought about transparency sort of leading up to this wasn't just of, do I have a clear, not just the idea that something was hidden from a patient is now available and clarity of benefits, but even thinking about across the continuum of care of a provider organization. So if I am caring for a patient in a hospital and I'm seeing that patient for the first time, do I have any insight into the history of that patient? Just thinking about what it means when we talk about improving quality, cost efficiency and quality of care. If you sort of boil it down to some of what it looks like in some individual encounters, one really simple example is, gosh, I wish I knew this about the patient's diagnostic history. If I had that information available to me at the point of care, I might make different clinical decisions, or I might not need to order tests that may have already been performed, or may actually, in some instances, may put the patient at risk because for many different types of procedures or diagnostics, there's a risk associated with it. So you think about, and that's just one microcosm. When you expand that out, you have the ability to reduce utilization and improve quality in incremental ways. And that's the way that we're going to make this better, not with a magic pill, but making better decisions every day, one at a time. One of the things on the financial side, if you go back in the past, I think, actually 2 points. One is if you were to go back to the last iteration of capitation, I think the capabilities of our technology was much more limited. And so we've got the possibility of doing things now that weren't possible before. The other thing is that if we were to, if you think about the economics, as I was describing the scenario, right under a traditional fee-for-service model, I don't have any incentives, and I probably don't have the dollars to invest in the systems to allow that physician to get access to the comprehensive medical record of the past. All my incentives are to order that test again because we get paid again. If you transition to different models of care, you can both provide the economic incentives for the investment to provide that information. So it creates alignment that can facilitate change.
I think the other important change is that our system is largely grown up around a physician model. As a physician myself, I can say, there's a lot of value from the role the physician plays. But moving ahead, we have to think, as you described it, a team approach, and that team has to have non-physicians who are practicing at the top of their license, doing the things that they're trained to do. If you came in and you designed the health system today from a fresh start, you wouldn't take somebody who's extraordinarily qualified and ask them to do something that is not at the top of what they're capable of doing. It would just be very inefficient. So in that regard, there's an important role that pharmacists play, for example, in being able to coach and counsel patients. The average diabetic is in CVS 8 to 10 times a month. How often do you think they see their doctor? Maybe once every 6 months, something like that. So there's a lot of opportunity there to impact somebody's health care that if we neglect that opportunity, we're losing a cost-effective and accessible source of care. We employ 3,000 nurse practitioners who do a terrific job taking care of patients. They have a wide scope of services. Study after study for the last 20 years has shown how effective and what high-quality care they provide. So it's not to say one in lieu of the other, but it's one in addition to another. And that will provide the most cost-effective system going forward, one that's thoughtful, and you have the right level of training providing the right service, doing it with a team that interacts about what they're finding. So I say that because part of what we're getting at around value has to design the model differently than it's been run in the past. If we keep doing the same thing, we're just going to have a really high-cost healthcare system that no one else in the world is doing, and frankly, I think we all agree has some real flaws. So that kind of approach is going to be important, and I think that's the direction that we're moving in. And we hear it every day from patients that they're looking for that kind of service.
About to turn to you guys. One more question for you, Andy, because across the street from the CVS that I do go to, just opened about a month ago a Carewell Urgent Care. And I'm just curious, and we keep hearing on the radio stations around Boston, new in Chestnut Hill, BI Urgent Care, ER certified docs. And Carewell, I actually went in because I was so curious. I was like, so what can you do? Tell me why I should come here. It's not to my MinuteClinic. But how do you position yourselves vis-a-vis these new things that are popping up all over town?
I'll make a couple comments about that. First, it's interesting, and I think indicative of the problem, how much walk-in care is developing in Massachusetts. Massachusetts actually has the highest number of primary care physicians per capita in the United States, okay? Imagine what the situation is in a state like Texas, right? I mean, there are more uninsured people in Texas than there are people in Massachusetts. So the situation, and obviously that's changing with the Affordable Care Act, but the situation is that even in Massachusetts, we have about 55 or 60 clinics, and many others are popping up. We think the role that we play is a very basic level of care, and we do it at a very affordable price. There are definitely things that fall outside of our scope, and we have good relationships with urgent care sites that do more than we do. Again, that gets back to my comment about you want the right level of care and the right level of provider providing the right level of service. So, we would certainly refer people to an urgent care or an emergency department when it's necessary. But the flip side is we don't necessarily want to use resources that are beyond what we need to take care of more basic problems. And I think that's the challenge in healthcare, and one that over time the market is going to work itself through and provide those resources.
If I may ask a question then, because I find that part fascinating, right? And then who can be the quarterback to coordinate the care for that person? The health plan wants to be that.
Yeah.
But they've done a poor job of demonstrating, at least historically, of playing that role, or they don't have much trust with their membership. So do you see an opportunity there?
Yeah, I personally think that still the primary care physician, primary care patient-centered medical home can be a place of coordination for patients. Now, having said that, a lot of people don't have one. And, that's a problem. We give lists of physicians taking new patients so we can get people into that system. I think the electronic integration of clinical information begins to bridge some of those gaps and is very, very important. We're affiliated with Cleveland Clinic, and UCLA, and Emory, and lots of other large systems, Lakeview, Bay State, where there's an opportunity to do some of that integration. Because you're right, coordination is going to be important in really deriving value and not duplicating resources or losing opportunities to treat people.
So let me turn it to all of you. What's on your mind? Yeah, sir.
So my question is about global payment models and kind of the current state. It's estimated that about 2/3 of payment financing arrangements are now it's in some type of a value-based contract. So there's pretty broad adoption. I'd love it if every panelist could comment on maybe one thing that works, and then perhaps if you have insight, something that's not working in terms of global payments and where they may be going.
Well, I think global payments work very well when you have a population that has a lot of medical need, like seniors or seniors who are duly eligible, Medicare and Medicaid, and a lot of resources put into, and data available put into integration. I remember the Tufts Health Plan when we went, well, that's actually not such a good example, but at the Medicare Advantage plan that they run, on average delivers primary care docs who are put in the financial position of steering the boat and reaping a lot of the rewards. They typically make 2 to 3 times what they can on fee for service. But those are people who need care. The dual eligible population for the disabled, which is a population under 65 that typically doesn't get enough care. When you put a coordinator in with a full budget, it actually ends up costing a huge amount because people are now getting care they didn't get that they needed. So it's great for that patient population, but it doesn't really financial results. So I think it has to be adapted very much to the patients, the kinds of providers that deal with them. And if you've seen one capitation, you've seen one capitation.
I'll give you an example of how, because we don't get globally paid, it really hurts our bottom line. We do a lot of virtual care, and we do it both through our patient portal, through telephone, and sometimes video as well. But we have 2 programs that work pretty well for us. One is we use an application called Twine that was developed by a doc who was getting his PhD at MIT, and we have probably 500 to 600 hypertensive patients in our practice. And when we diagnose a patient with hypertension, we can get that person controlled, their blood pressure controlled in less than a month, where in the kind of typical scenario, it takes 3 to 6 months of many times for a patient to come back. But because that patient connects with our nurse over this app and checks their own blood pressure, talk about engagement, checking their own blood pressure, and talking to the nurse online, that nurse can then increase their blood pressure medicine and get that patient to goal very quickly. Well, that's fine, but we don't get paid for any of that time. And so a global payment would really help us.
You said it's called Twine?
Yes, Twine, yeah.
I'd say it's very heterogeneous. I mean, I was at Partners 15 years ago, and we thought by now everyone would be 100% on global payment. And, in some parts of the country, that's certainly the case. If you go to California, the models that, Kaiser or Sharp Healthcare have, they're very established. And frankly, the patients get excellent care. I mean, if you go by any objective benchmark of performance, the surround sound focus on quality and other metrics is impressive. But when you leave that area, the adoption is quite varied around the country. And part of it is it takes a lot of patience, so you have to have scale to do global risk. And it takes a lot of infrastructure and population health management capabilities, data management capabilities, case manager infrastructure, extended care capabilities, pharmacy management. There's a lot to it. I think there are many systems around the country, even very accomplished, well-known places, that are really just at the beginning of the beginning to march in that direction and have a lot of steps to go through before they're ready for that. I think they're thinking about it, but right now achieving quality objectives or small measures of risk are mostly where they are. And I think everybody's looking to see, how quickly do I have to move on that continuum. To my eye, the payers are driving it because they're duplicating the governmental ACO type programs with their own commercial or oriented ACOs. And once we get to a certain tipping point, it may move more quickly. But you could go to a lot of markets around the country, as I do, you'd have trouble identifying this as anywhere near global capitation. Value for sure, little risk examples, yes, but not the kind of wholesome model that you might see at an Atrius or Kaiser or something like that.
I agree with Andy. I mean, the numbers, if you go outside of this market, with very few exceptions, it's very much an infancy, and risk is more rare. I think you're talking about shared safety. For me, the measure is, and actually for me, in some ways, the most meaningful tipping point isn't risk. It's measurement on the total cost of care. It's upside. It's the carrot versus the stick. Both important. But I just make 2 other comments to add on here. One is, I think when you're saying what's successful, I think it depends on who you ask. Going to John's example in the beginning on Tufts Health Plan, and this is my evidence is more anecdotal, but I think that I do understand that on the Tufts Medicare Advantage risk arrangements, many of the primary care physicians did very well. A lot of the hospitals got killed. because the incentives became, under the system, under the model of reimbursement, a hospital received a fixed payment essentially based on a DRG per admission. I think if you looked at the average length of stay and the average cost of those admissions, they were higher than non-Medicare patients because it was in the interest of the physicians to keep the patient in the hospital longer to make sure they were, than they might have otherwise. And there are implications in my comments that people can contest with, but I think there's evidence that I've seen that supports that. So when you're saying is it successful, I think you need to, say for whom the goal should be, in its entirety.
Yeah, and I think ultimately, I meant that, I'm sorry I didn't clarify,
Yeah, no.
in terms of the AAA.
Sure.
So
yeah.
ultimately, that's what I think we could all agree around, but then
Yep.
you're right, there's different
Yep.
perspectives.
And so one other thing I think in terms of one of the things that's necessary as we do move to these models, we talk about alignment of incentives. I think a lot is put in between, was talked about in terms of the incentives between a payer and a provider. But when you think, let's talk about it in the context of a partners, which is an enormous organization. You think about, so you've got incentives between those two organizations, but the care is delivered many, many layers below that. So what's the incentive for the nurse practitioner who's doing the intake at, in one of the practices to change the way they deliver care? And so how do you make sure that the incentives are aligned all the way along the continuum to the point where the decisions are being made? And I think we've got a lot of work to do in that.
David, anything else?
And then just the only thing I would add to that is then the challenge of aligning the IT systems to support that, because there's a lot of work there. But I do think too, the other thing that might be helpful as well is if, as we put these new models in place to maybe throw some risk corridors out there so not one person wins and another person loses. So we can, if the goal is to ultimately drive, not take the cost trend down, but really just make an improvement in health and population health, we should be less concerned, especially for the nonprofit entities, less concerned about the profit motive in medicine.
Yes, please, you had a question.
Yeah, thanks. This question is for Andy, actually. So I'm actually a former Epic employee, so thank you for the kind words. And so obviously from that respect, I do know that technology can go a long way towards that goal of standardization in care. However, I think having healthcare providers, there's an art to what they do, and standardizing what a healthcare provider does at 980 MinuteClinic locations is not the same thing as standardizing how many French fries I get when I go to a McDonald's on this side of the country versus the other. So I'm interested more from an organizational or managerial perspective. What does CVS and MinuteClinic do to kind of ensure that standardization?
Yeah, good question. And I think it's important to say it's not meant to be the McDonald's French fry example. It's meant to say, is there a guideline when a person presents with fairly similar symptoms to somebody else, and you have a choice between two different therapies, can we go with the therapy that actually has some evidence behind it as opposed to another? And that's the kind of standardization we don't just need at MinuteClinic, we need in healthcare in general. Look, it was 100 years before we used a checklist in an operating room. It's like a genius thing, and I love a tool, Blondie, and he's on the hall. It'd be a great idea, he's exactly right. Why wouldn't we? Like, we use it in an airplane because we're worried that something would go wrong. Why wouldn't we use that in an operating room? There's nothing that represents, I think, a level of standardization that's just about safety and reliability. And medicine can learn a lot from the business world around safety and reliability and duplication, because most people don't have something exceptional. And of course, you need to have the right set of criteria to say, hey, when this person's got a high fever, or when this person has this other problematic vital sign, they're off the path, they need to go to a more complex setting. But when people have relatively consistent findings, when there is evidence behind what the right care is, that's probably the care that they should get. And I think that's the objective. And so we spend a lot of time educating people. We put it in our EMR as reminders and guardrails to suggest different kinds of treatments that the evidence would derive as the best therapy.
Any questions from this side? Yes.
I'm interested in the legacy of the baby boomer generation, especially as a member of the generation who's getting ready to help pay for it. I'm interested in our ability to do things for people continues to outstrip, or I'm interested in the question of what we can do versus what we should do, and the role of the payer and provider, and increasingly the payer/provider in affecting that conversation in this country?
Well, I just say I think there are a number of important tools, and the lens that we bring to it is more the pharmacy side. So we manage pharmacy benefits for millions of Americans. And there's certainly an opportunity to say, hey, here's a formulary, here's a list of medications that a group of experts in the clinical field would say these are the preferred drugs. These drugs on the side are really costly. They accomplish the same thing as the things on this list. Or before somebody starts an expensive therapy, is there a less expensive, just as effective therapy that should be the first stop before you go to the much more elaborate drug? And those are the kinds of decisions that actually employers and health plans are making every single day, in effect forcing that issue, which is to say, can we use our resources most responsibly? That's what we're going to have to do. Because you're right, there's a ton of stuff we could do if we just had a blank piece of paper, but the consequence of that would be we might spend a ton of money in a desperate situation at the end of somebody's life that might be futile, and not have money for prevention at the beginning of somebody's life, and we could really help intervene at relatively low cost. So that kind of balance is going to be imperative as we go forward, and it's happening, in a variety of different ways in health plans and governmental programs.
I might just add, the way you frame the question, I really appreciate it, because when you think about what, you use the pronoun I, or we, I think, and it's not just a professional question. It's not just about payers and providers and these kind of things that sit right up here. It's what can you do? And when I think about it personally, because I spent 5 years in this space, it's like, what can you do as a son, as a spouse, as a good friend, as a colleague at work, when someone you know has a chronic illness or is dying? Well, what's your role in this? I mean, I spent 5 years asking questions about that, and what I found out is the default in this country was two things. Sympathy in a casserole. People who are dying or really sick, that's what lay America knows what to do. I actually think that everyone in this room can do a lot more than those two things. And so when you think of what are the payers going to do, and what's MGH going to do in the future practice, and can you get to the MinuteClinic? Well, what can you do? And what can your role be? What's the informal coach? How do you sort of organize some of the material that help family make decisions, have a conversation about quality of life and what matters, to inform the conversation that they will have before they meet with the clinician and things like that. I think it really matters, and people skip that step every day.
Can I say something about that too, just very quickly? Because our primary care providers are so stressed with having to see so many patients, this is a really, really important question to have before a person gets really sick. And a lot of people never get around to it because it takes me or any other healthcare provider 20 minutes just to reconcile the 25 medicines that the patient is on, and they're not sure whether they're on them or not. But that, in my mind, although that's a meaningful use thing, and I really have to do that to be safe with my patients, what might have been more important is for me to spend 20 minutes with that person talking to them about, tell me what you want your end of your life to be like. Tell me how far you want people to go. And sometimes they leave it to their kids who don't want to lose mommy and daddy, and that's not right. And so that's why it's great to have more time.
And so there's, some people probably know this, there's an experiment, I can't remember which town it was in Wisconsin, where every time you encountered the hospital, you had to create a directive, which of course was meaningless for somebody who did it when they were 25, when they're 65, but what it did do was start the conversation within the family about, gee, what does my son and my father really want? The other thing I was going to, so there are sort of systematic ways to do it. The other thing I was going to mention, though, is that as the line between acute care, long-term care, and social supports degrades as you age, and that's the sort of limitless amount of services that we could be eating up. The role for entrepreneurs, actually, the space for entrepreneurs increases. I think government will do a pretty good job. We can only borrow so much from the Chinese and saying this is what Medicare will pay for and won't pay for all that other stuff. But there's lots of technology and services and technologically enabled services that families and households will be needing and demanding that private industry can provide. And the good news is you don't have to get a third party to reimburse it. It's not free to the patient, so it's not quite the growth market we have for pharmaceuticals, but there's a lot of opportunity there.
Yes, sir.
I wanted to comment to that, because I think in ways we're talking about high deductible plans and things of that nature as well. We're all paying for the baby boomers because that's kind of the shift. Baby boomers are working a lot longer. Private companies, even like Boston University, have changed how they cover their employees, and I work for Boston University. We now are going to have deductibles moving forward, so we're paying for it as well. But my question, and Dr. Sussman, to you, they are now starting to, or I'm going to start to support more of the my family, my friends, my coworkers, support more of the healthcare system. And what's going to happen when patients can't? I mean, I was thinking more originally when I had the question of uninsured patients, but as a one-income household myself with my wife and 3 children, one with severe disabilities, it becomes a struggle every year to access care, even for someone like myself who's doing relatively well with Boston University. What happens, though, when someone walks into a MinuteClinic, for instance, they see your transparent fee structure but can't afford it?
Yeah, good question. So, firstly, I'd say the real problem, just globally, is not so much that someone can't afford $50 at a MinuteClinic. The problem is that they can't afford $1,000 at an emergency room. And the one flaw in the high deductible logic is think about where most of the healthcare costs go. They don't go really to the sore throats and the stuffy noses. Most of the healthcare costs go to really seriously ill people, and they're actually beyond their deductible, almost by definition, right? So it's that part of it that the high deductible plan really doesn't solve. So I don't want us to think like, hey, that's a panacea because of the issues that you're raising. You know, we wind up referring people to providers of all types, depending on what their circumstances are. And when we see people who are not of means, we'll send them to a health center for follow-up, and after we would evaluate them. And you know, and that varies, and it depends in some cases. Like in Rhode Island, we provide free care to the Rhode Island Free Clinic patients. So it just depends. But I would say that the main issue isn't on the low-cost stuff. We wind up being a site of care for people that can't go anywhere else because we're much less expensive. In fact, our regular prices often equal what someone else's copay or deductible would be. So we're actually a good site for them for care. What we don't want to become is their permanent site of care, right? Because we have a narrow scope. We really want to send them on to a more permanent site that they can afford to get treatment.
Yeah, Aaron? One thing I was really curious about in terms of differing models, one of David's comments was actually, that health plans can actually be pretty bad at coordinating care. And what I was curious about is you kind of have 2 models that are approaching a critical mass, right? One side that says, I'm going to vertically integrate, and I didn't have 50 years to do that, I'm going to go out there and acquire. And you end up now with differentiated health plans, right? Things that are very high value, differentiated health systems, very high value. And then you can end up with a war zone, which is what Western Pennsylvania looks like these days, between UPMC and Highmark. And so I guess I'm curious, since we have differentiated health plans, differentiated providers, positions that are very difficult to move somebody beyond. You know, how big is the temptation to be able to say, I'm going to control my own destiny. I, as a differentiated health plan, am going to buy a hospital. I, as a differentiated hospital, am going to buy a health plan. I mean, Dr. Slavin this morning was talking about Medicare Advantage. He never talked about neighborhood health. That's true. And so what really interests me is, I guess, where's the tipping point of diminishing returns? If someone wants to control their own destiny, says, I'm really serious about controlling costs, I have this phantom ACO I can build, empowered by a health insurer, linked with 7 health systems, or I can do it the other way.
Any thoughts on that, panel?
Yeah, I'll make a comment. I mean, I think the example that you provide in Pittsburgh is, I would say, uncommon in the United States, at least in my experience. So there's always that challenge. You look over the fence in your backyard and you look at your neighbor's lawn and you say, God, that lawn is so green, I could do that. And I think that's a little bit of the challenge a health system has when they look at providing an insurance product, because it might seem like it's a relatively straightforward set of skills that are required, but actually it's quite complex and has an enormous amount of risk associated with it. And the opposite is true for a health plan looking to become a provider. Now, there are instances and examples, I mentioned a few before, that it's been done quite well, like Kaiser. But in general, it's a big ask. And a lot of the places that try to vertically integrate have struggled. Now, Medicare Advantage is definitely bringing some of these health systems around to that in some capability. But I think that while some systems own small plans, we don't see the Pittsburgh situation in too many other locations. And I think vertical integration is a big challenge. And you have to wonder whether you really need to own all the member development and IT and all the other capabilities, or you just have to know how to manage care and let Aetna or United deal with that part and just do well on the contracts you have. I personally am a little skeptical about whether health systems are going to jump in with both feet into that space. And some have struggled. I mean, you gave an example in your comments. So some have struggled with that because it's not necessarily an easy thing to master.
The problem, I think, though, is that we do, it's sort of a reflex reaction to uncertainty is to amass, to get bigger, to merge, to crowd for safety. And that would be fine in most industries. Healthcare has such incredible barriers to entry. The idea you're going to, UPMC with its 50-chair board of directors overlooking all of Pittsburgh, in plush leather and 3-inch carpets. I mean, there's such an opening for somebody to compete. There's no way to start another premier academic medical center in Pittsburgh and take away market share from these established behemoths. So I actually see, in a way, UPMC going into the insurance business and across of Western Pennsylvania going into the healthcare business as sort of the logical culmination of, you got a huge insurance company, huge academic medical center, they can't live with each other, so they just go into each other's business. And ironically, the result is now at least you have two competing sets of systems. So I don't know. I think this is a tough market to get new entrants into, and that makes the economics really screwy. So they see
Jim, last comment on this, and then we're going to have to wrap up.
Just one thing. I mean, I think when you look at, it's easy to look at, you brought up the example of Kaiser, and you can bring up selected examples across the country as models. I think the idea that saying, gosh, that model works, we should go do that, and we'll buy the component parts of it, I think is naive in many respects, because Kaiser didn't just decide to buy the parts. They've got decades of a history of a culture of being in, all of the incentives that, create various degrees of alignment from top to bottom that reflects who they are. You can't simply, buy the parts and become that. I think so it's a local business after all. I mean, at the end of the day, and I think that, I think it's naive to think you can just build that overnight.
So David, Jim, Andy, Jane, and John, thank you very much for your time. Help me preview. One is logistics, and the second is logistics. The first part of logistics is elevators are sometimes slow. You can take the stairs right here down to the second floor and then come out, and then take the stairs all the way down to the lobby. That might be faster. Secondly, we will be kicking into gear at exactly 3:50 in the auditorium. The beginning of the program is actually, I want to give you a preview of an award we're giving to Andy Sussman, an achievement award, so I hope that you'll all be there, just as we go into the keynote of insurance with Andrew Dreyfus. So please shoot to be in the auditorium about 3:45. That gives you about less than 15 minutes. Thank you.